Recording. Take it away. Thank you so much.
Awesome. Thank you, Adam, for the introduction, and thank you for inviting me to be here virtually with you all today. Thank you all for being here and taking your time to listen in. So I have no disclosures, and I guess I should just repeat what Adam said. My name is Judy Gadde. I am a pediatric neuroradiologist here at Lurie Children's Hospital of Chicago, and am our Director of Academic Innovation and Pediatric Radiology Rotation Site Director. So the objectives for my talk, we will first go over the International League Against Epilepsy classification of focal cortical dysplasia, which is the most recent classification system that is used, and then I'll show some examples of those. And then additionally review some additional causes of epilepsy, including migrational anomalies, genetic mutations, tumors, etc. And then at the end, I will briefly cover some phacomatoses that are related to epilepsy, but you should stay tuned to September's lecture to hear more about phacomatoses. So starting off with developmental malformations, as I mentioned, the current classification system that we use is from 2011 from the International League Against Epilepsy. As you can see here, there's three major types of focal cortical dysplasia, and the descriptions are the pathologic or histologic findings that are seen. And ones that we see more commonly on imaging are going to be type 2 and type 3 as well. And we'll go through each of these in more detail. And I should say thank you to Dr. Aaron Simon Schwartz from Children's Hospital of Philadelphia for a few of the upcoming cases that I'll show you of pathologically proven focal cortical dysplasia. Several of these cases are ones from when I was a fellow there, which was from 2016 to 2017. And we have presented these cases at other places as well. So focal cortical dysplasia type 1 is isolated. You can see there's type 1A, 1B, and 1C. And these are usually not visible on MRI, but they can be seen. And I have some pathologically proven cases that I'll show you. Some of the findings that you can see are segmental or lobar hypoplasia atrophy. And this will most commonly be at the gray-white matter junction. And you'll see a theme throughout these focal cortical dysplasia cases of abnormal sulcal and gyral patterns. So here's our first pathologically proven case of type 1A. Give you a second to take a look at this coronal 3D T1. And then with our green circle here, we can now see, hopefully it is subtle. A lot of these cases are going to be subtle. They're involving the cortex. On this right side, we can see some blurring of the cortex. Like if you look on the contralateral side, you can see this well-demarcated differentiation between the cortex and gray matter and the adjacent white matter. So just to show you, these can be very subtle, but if you take enough time to look at these cases, and if you have the proper imaging, meaning an epilepsy protocol, which will include a 3D T1, then these can sometimes be found. And then moving on to type 2. So type 2A is focal cortical dysplasia with dysmorphic neurons. Again, this is not always seen on MRI, but it can be seen. Some findings are blurring at the gray-white matter junction, and these are less commonly seen than type 2B. So here's a case of type 2A. Give you a second to take a look at this axial T1. Again, a 3D sequence is very important. And then this is a fused PET MR. So here in the left frontal lobe, we have this abnormally deep sulcus, and we can see that the gray matter and cortex associated with this gyrus and sulcus is very thick and looks a little blurred at that gray-white matter junction if we compare, say, to the contralateral right frontal lobe. And then on our corresponding PET MR, this must have been a ictal PET, so meaning that this was during a seizure or soon after a seizure. We have increased FDG uptake in that corresponding gyrus, consistent with type 2A. Another case of type 2A, give you a second to take a look at this coronal T2 and coronal T1. This one is very subtle. I would say even more subtle on the coronal T2 here. Maybe that cortex is a little thickened compared to the contralateral side and compared to other regions. And then if we look at the coronal T1, I think this is where it's really helpful because again, we can see that blurring of the cortex compared to the contralateral side. Type 2B, this is probably what you're more commonly going to see and what you're more familiar with. So this pathologically is dysmorphic neurons and balloon cells, some of the same findings as on the prior types. Blurring of the gray-white matter junction can have increased T2 flare signal in the adjacent subcortical white matter. Something important that we often see with type 2B is transmantle dysplasia. And I'll show you an example of this, but this is basically where the abnormal signal in the white matter tapers from the crown of the gyrus to the ipsilateral ventricle, and it's usually going to be the frontal horn of the lateral ventricle. Again, similar to others, can also see abnormal cortical gyration and sulcation, which may be as subtle as just seeing focal enlargement of the overlying subarachnoid space. Here's our first case of type 2B. I think this one's not as subtle. So here in this right temporal lobe, we can see abnormal T2 hyperintensity in the subcortical white matter. We can also notice thickening of that cortex. And then on the coronal T1 here, we have abnormal T1 hypointensity in the white matter. And again, this is type 2B. Another type 2B, this is again, that more common transmantle dysplasia, or you might read in the literature or hear people referred to as Taylor balloon cell type dysplasia. That's referring to the old classification involving type 2B. So here, again, we can see abnormal T2 flare hyperintensity involving the subcortical white matter of this left frontal lobe. And then we see that typical transmantle dysplasia where it's tapering from the crown of the gyrus to the ipsilateral frontal horn. And then on the other image here on the right of the screen, this is a special sequence called T1 magnetization transfer. Not sure how commonly this is done at other institutions. Here, we very rarely do it, but it is an optional sequence. And it helps areas of abnormal signal stand out by trying to get rid of some of the normal T1 signal. So here we can see the corresponding abnormal signal in that left frontal lobe. And then type 3 means that it's associated with a lesion. So these can be very hard to find because you're so focused on the associated abnormality. And we'll go through these, but just for purposes, type 3A is going to be when it's associated with hippocampal or mesial temporal sclerosis. Then type 3B is if it's adjacent to a glial or glioneuronal tumor. C, if it's associated with the vascular malformation, and then D is pretty much anything else that has been acquired during early life. So here we have an example of type 3A. So remember, this is when you have focal cortical dysplasia associated with hippocampal or mesial temporal sclerosis. On our coronal T2 and coronal T2 flare here, we see an abnormally and asymmetrically small left hippocampus with abnormal T2 flare hyperintensity within it, which we often see with hippocampal or mesial temporal sclerosis. And then on the coronal T2 on the upper right of your screen, this is very subtle, but if you look in the white matter of that left temporal lobe, it is asymmetrically T2 hyperintense compared to the contralateral lobe. And then if you don't believe me, When I was at CHOP, they often, and I think they still probably do, DTI on pretty much every patient. And this can be helpful actually finding focal cortical dysplasia. So here, if we look at the normal contralateral green fibers on the right, we can see in that left anterior temporal lobe that they're blurred and not as well seen. And this can help confirm that there is an underlying abnormality there. Then type 3b, if you remember, is when it's associated with a glial or glioneuronal tumor. This is very subtle, but again, these are all pathologically proven. And here, if we look in the left parahippocampal gyrus, we can see very subtle T2 hyperintensity. You can compare that here to the contralateral right side. And this is an axial T2 flare, I think maybe more of a 3D sequence. And this ended up being a ganglioglioma with associated focal cortical dysplasia. So even if we go back and look at that mesial temporal sclerosis case for the type 3A, sometimes we might just see the T2 hyperintensity in the hippocampus and move on. But it's important in all of these cases to look at the surrounding white matter and see if the area of signal abnormality extends beyond what you would expect, because then the pathologist and the neurosurgeons, if they end up resecting it, will be more suspicious and more, I guess, judicious looking for that focal cortical dysplasia. Here's another example from here at Lurie of a type 3B. So this was a low-grade glioma. This was resected and pathologically proven. We had been following it for a while. So here we can see some abnormal signal in this right parasagittal frontal lobe involving the cingulate gyrus. We can see this susceptibility in T2 hypointensity that ended up being calcification, as we would expect. And then there's surrounding T2 hyperintensity. On the pre-T1 on the upper right, there's maybe just a few stippled areas of T1 intrinsic hyperintensity, but then post-contrast, there was some enhancement. And you can even notice here like a little bit of enhancement in T2 hypointensity going towards that ipsilateral frontal horn. And again, this ended up being a low-grade glioma with associated focal cortical dysplasia. And then type 3C is when it's associated with a vascular malformation. So this ended up being an interesting AVM in the right frontal lobe in that region of the right frontal operculum. There's some cystic change, cystic encephalomalacia. We can see the nidus of vessels, which was demonstrated on the DSA. And you might just see the abnormal T2 hyperintensity and think it's probably some gliosis associated with the AVM. But again, this ended up having associated focal cortical dysplasia. And then lastly, our last type is going to be type 3D. And this is when it's associated with something else that was acquired early in life. This ended up being an HSV encephalitis case. And this was the initial presentation. We can see abnormal T2 flare hyperintensity in the right frontal lobe right temporal lobe anteriorly. On the coronal T2, we have additional T2 hyperintensity involving that right parahippocampal gyrus, maybe even extending to involve a portion of the hippocampus. And on the DWI and ADC, we had some restricted diffusion more medially. So the patient was treated and then developed seizures. And this was follow-up imaging where we see some cystic encephalomalacia now in that medial right temporal lobe, but there's still some surrounding T2 flare hyperintensity. We can see that both on the axial T2 flare and on the coronal T2. And again, you might just think this is gliosis, but given the fact that they had persistent seizures, they ended up resecting this, and it again was focal cortical dysplasia type 3D. So just important to keep in mind that not all T2 flare hyperintensity that you see is going to be gliosis or vasogenic edema. If they have seizures, especially if they're medically refractory, try to keep focal cortical dysplasia in the back of your mind. Okay, so moving on to some other causes of epilepsy. Gray matter heterotopia. This can be sporadic or familial. It can be associated with other brain anomalies, including Chiari2, cerebellar hypoplasia, PMG being polymicrogyria, which we will talk more about, ectopic posterior pituitary, agenesis of the corpus callosum, etc. If the patient just has an isolated gray matter heterotopia, they can have mild clinical symptoms and typically will have onset of seizures in the first or second decade of life. And pretty much like everything that we're going to talk about and have talked about thus far, they can also have potentially focal cortical dysplasia in the overlying cortex. So here's an example of a subtle subependymal gray matter heterotopia. We have axial T2 and T1, again, a 3D sequence. And we can see abnormal gray matter signal along the atrium of the left lateral ventricle. I would say this location in particular is very tricky because, as we can see on the contralateral side, this is where the caudate tail will often be seen, like here on the right, but it should never be this far posterior. And one thing that helps me find subependymal gray matter heterotopia in particular is when there's an indentation, kind of like a concavity into the lateral ventricles. That can help be a sign. And of course, this will follow gray matter on all sequences. More extensive bilateral subependymal gray matter heterotopia, I think there's no question that probably the majority of us could see this, and again, pretty extensive along the bilateral lateral ventricles. Moving on to polymicrogyria, I like to describe this as trainees. I don't know if anyone else does this, but I like to describe it as like lumpy bumpy. So it's excessively small and disorganized gyral convolutions with shallow sulci. And there are several causes. It can be due to an intrauterine infection, like if you think about CMV, can be seen with ischemia, or there are also multiple genetic mutations that can result in polymicrogyria. The symptoms will vary with the extent and location. Most commonly, they will have seizures, of course, developmental delay, and spasticity. It can be unilateral. If it is unilateral, will often lead to hemiparesis and again, seizures. And then just to be familiar with something called congenital bilateral perisylvian syndrome. So this is when you have bilateral perisylvian polymicrogyria, and they often will have oromotor dysfunction and seizure disorder. So here's an example of that bilateral perisylvian polymicrogyria. This is not super uncommon. I've seen several cases of this so far in my practice. And again, I think it's just helpful, at least for me, to describe these as like lumpy bumpy. On axials, I think it can be a little tricky to pass by this, but super important, of course, to look at your other sequences and look at all imaging planes. So here on the coronal, I think it makes it look a little more obvious that these are way too many gyri, and again, is that lumpy bumpy and pretty symmetric bilateral, and we can again see that on the axial T2. So moving on to genetic mutations, wanted to talk about hemimegalencephaly. So this is actually a hematomatous overgrowth of all or a part of the cerebral hemisphere and tends to be sporadic. Half of these patients have other associated anomalies, so just something to keep in mind. You know, as a radiologist, we don't want to have satisfaction of search, so keep on looking. You can have total hemimegalencephaly, which I don't think I've seen yet in my practice, but this can involve the ipsilateral cerebellum and brainstem, so not just the cerebrum. And these patients will classically present with macrocephaly at birth, so something to keep in mind. Of course, they will present with seizures. That's why we're talking about it today. And then hemiplegia and severe developmental delay. So here's an example of a 6-month-old male who presented with seizures. Sometimes it might be hard to tell in these cases which side is abnormal and which is normal. So with hemimegalencephaly, it's going to be the larger side since it's a hamartomatous overgrowth. So here we can see the right cerebral hemisphere is asymmetrically larger than the left, and even we can tell that that right calvarium is larger than the right, or the right is larger than the left, sorry. And usually the ipsilateral lateral ventricles will be enlarged. So here we can see, especially posterior, this right lateral ventricle is enlarged. And often the involved cerebral hemisphere will have abnormal myelination. So here we can see both on the T1 and T2 abnormal myelination in that right cerebral hemisphere, and it's classically hypermyelinated, so more myelination than we would expect for the patient's age. And then I also want to talk about Aicardi syndrome. So in the literature, it says this is rare, but I feel like I see multiple cases a year. It is important to remember that it's X-linked because since it is X-linked, it's fatal in males for the most part. And the classic triad that they have is infantile spasms, corpus callosal dysgenesis. So dysgenesis meaning it could be agenesis or just partially developed. And then something we won't see, but chorioretinal lacunae. They can have multiple anomalies as you see here, and I'll show you an example, but multiple anomalies in the brain, multiple anomalies involving the eye and the spine. So my takeaway for this is think of this syndrome when you're evaluating a female with infantile spasms and multiple CNS malformations, especially multiple intracranial cyst. I find that most helpful. So here's a 2-year-old female with this diagnosis. We can see parallel orientation of her lateral ventricles on the axial. So that's a good sign that there's at least corpus callosal dysgenesis, if not agenesis. And then we see probably multiple areas of polymicrogyria. We can see here in this left frontal lobe. And we also have some abnormal gray matter signal along the anterior aspect of this left lateral ventricle, probably some subependymal gray matter heterotopia along with the polymicrogyria. And then on the image in the middle, even though this is a T1, we can still see that there's a cyst in this posterior right lateral ventricle. So remember, you can have multiple cysts. We have another cyst lateral to the left cerebellum, and then another cyst in this right cerebellomedullary or cerebellopontine angle cistern. And then lastly, they can get colobomas. So here on this axial T1 in the middle, we can see that classic posterior protrusion along the globe contour where the optic nerve head inserts that we often see with the coloboma. Okay, we will move on to tumors. There's several cortical tumors to cover. So the first one is dysembryoplastic neuroepithelial tumor, or you might see abbreviated as DNET. This is a benign mass of the cerebral cortex. It is WHO grade 1. I had to go back through this lecture and change them all to not be Roman numerals in keeping with the new WHO classification. And just like all of these tumors that I'm going to discuss, these often will present with seizures. Also, all of these tumors are going to be listed as more common in the temporal lobe, but they can occur in other lobes. And also, all of these tumors can have associated focal cortical dysplasia, which we've already talked about, and that would be type 3B because it's a glial or glioneuronal tumor. And DNET often will be well demarcated, lobulated, or you might hear people refer to it as bubbly cortical mass, and bubbly in the sense that it's T2 hyperintense. And again, the majority of these tumors I'm going to tell you today can enhance. They may or may not enhance. It doesn't make too much of a difference in regards to differential if it enhances. So here, this case is a 9-year-old female who presented with seizures. We can see this large T2 hyperintense mass in this anterior right temporal lobe, kind of bubbly, lobulated, no susceptibility on our GRE or SWI, And then in this case, post contrast here on this T1 on the right did not really have much enhancement, but again, doesn't matter too much. Pretty much just looking at the axial T2, one of the things you should think about is a DNET. And then this is another case. This was a 2-year-old female who presented with seizures. And here we can see this T2 hyperintensity involving the cortex and adjacent subcortical white matter in the left occipital lobe. In the middle here, this is a sagittal 3D T2 flare, and we can see there's maybe a couple little actual cysts in this region, one adjacent to that occipital horn of the left lateral ventricle, and then we see some associated T2 flare hyperintensity. And then post contrast on the sagittal, there was maybe this small area, round area of enhancement. And interestingly, this ended up being a DNET with focal cortical dysplasia. So this is, again, that type 3B. So very important when they go in to do a resection that they take out all of that area of signal abnormality. The next tumor is a PXA, which stands for pleomorphic xanthroastrocytoma. This is rare. It is a low-grade tumor, WHO grade 2. Again, most of these patients are going to present with seizures since it involves the cortex and most commonly in the temporal lobe. These are also well circumscribed. They're not going to be as bubbly as that DNET. And these tend to have more vivid enhancement, and up to half of them can have cyst. So here's a case of a 14-year-old male with seizures. We can see this mostly T2 hyperintense and maybe some small cyst mass on the left. There's even some surrounding T2 hyperintensity. As far as I know, this did not have associated focal cortical dysplasia. And then we see a larger cyst. The solid component does demonstrate avid enhancement. Sorry about that. And this case, we happen to do DSC perfusion on, and you can see it's really dark on the DSC perfusion, which tells us that it's hypoperfusing and most likely not going to be high grade. And again, this was a PXA. Next up, we have a ganglioglioma. These can be WHO grade 1 or 2. They say that they're uncommon. And about half of these patients will present with seizures, especially if it's cortical in location. Again, most common in the temporal lobe. And you'll see the description here for ganglioglioma can pretty much be anything. It can be solid, it can be cystic with a nodule, mini cyst. But if there is a solid component, even that can variably enhance. So basically saying that the the description and the appearance can be very variable. So here, this was a case of a 15-year-old male who actually presented with enuresis and fatigue, which I found interesting. And we can see this focal area, very small, T2 hyperintense. And then there's some surrounding T2 hyperintensity anteriorly. Same thing here on the coronal T2. It looks like this is involving the parahippocampal gyrus, has some associated T2 hyperintensity. And then actually, if we look at that right hippocampus, it looks like it also has abnormal T2 hyperintensity within it. And then if you did just the non-contrast portion, you might just be tempted to call this a cyst and move on. But actually, what looks like a cyst ends up having very vivid enhancement. So this ended up being, again, a ganglioglioma, and I'm pretty sure this case didn't have associated focal cortical dysplasia given the amount of surrounding T2 hyperintensity and involvement of that right hippocampus. Next up is mesial temporal or hippocampal sclerosis. They say that this is the most common entity in patients undergoing epilepsy surgery, but I think that's speaking more to the adults. And we've already seen a case of this when we were talking about focal cortical dysplasia, but things to look for are going to be hippocampal atrophy, associated T2 flare hyperintensity, loss of that normal internal architecture. Secondary signs would be dilation of the ipsilateral temporal horn And then another secondary sign, if it's advanced, will be atrophy of the ipsilateral mammillary bodies and fornices. I feel like I see that more commonly in adults than children. So this was a child who presented with focal epilepsy, and the initial imaging here was read as normal. And then they developed malignant hypertension. 4 months later, they had repeat imaging. And here we can see that the left hippocampus is now asymmetrically small compared to the right. And we can see that is new compared to the prior. And then on the coronal T2 flare here, there is also just maybe a little subtle T2 flare hyperintensity, kind of hard to tell. But I think more easier to see would be the very minimal increase in size of that left temporal horn, showing us that there's atrophy of that left hippocampus. Okay, I'm actually like speeding through. So to end off with a couple of phacomatoses, this first one I wanted to talk about is tuberous sclerosis. So tuberous sclerosis is actually hamartomas of multiple organs, including the CNS, skin, bone, kidney. It is autosomal dominant. There are 2 different genes on 2 different chromosomes, as you can see here, TSC, so tuberous sclerosis complex 1 and 2 genes. And I think it's just interesting because the names of these are Hamerton and Tuberin, which makes sense with the diagnosis. I will say, hopefully you should never be asked on a board exam for a gene or chromosome, at least in today's current environment. That would not be a good use of your time, but still important to know clinically. And again, like most of these cases, about 90% of these patients, which is pretty high, will present with seizures, often infantile spasms or myoclonic seizures. That might not seem super important for us as radiologists, but sometimes we will get imaging requests that specifically say infantile spasms or myoclonic seizures, or you go into their electronic medical record and you look at an EEG or a neurologist note and get that information. That maybe could clue you in that it's not just a classic seizure case or epilepsy case. And unfortunately, about half of these patients do end up having cognitive impairment. So I just wanted to show the diagnostic criteria for tuberous sclerosis. We obviously don't have to know all of these because a lot of these are going to be things that you can see clinically, but I think are still important for us to be familiar with because we might read it in the notes or hear about it. And there are major and minor features. A lot of these are skin findings since they can get hamartomas of the skin. Some things that might sound familiar to when you were in medical school or taking some other exams, like there's a shagreen patch. Some other skin findings would be like angiofibromas, hypomelanotic macules. And then some of the findings that we can see would be multiple retinal hamartomas. Sometimes we can see those, but that's going to be more of a physical exam finding. And as we'll see in my example, subependymal nodules, subependymal giant cell astrocytoma is going to be when those nodules begin to enlarge. And they also can have some abdominal findings, so multiple renal cyst. And then one thing that they often will get screened for, and I will get repeat imaging to evaluate for, would be angiomyolipomas or AMLs. And then also remember cardiac rhabdomyomas, and then the lung finding of lymphangioliomyomatosis or LAM, which can also be seen in other clinical settings. So just things to keep in mind. Here's a 12-year-old male who presented with seizures. And here we have a couple of findings. So on the left of the screen on this axial T2, we can see some abnormal T2 hyperintensity in the subcortical white matter of the frontal lobes. We can see some expansion of the overlying cortex and gyri. And if you saw, I kind of skimmed over it, but on that list, it said cortical dysplasia and then had an asterisk. And these, we often will refer to as cortical or subcortical tubers on our imaging. But pathologically, if they look at these under a microscope, it looks the same as focal cortical dysplasia. These patients will often have multiple of these and they're bilateral, and this is what actually causes their seizures. So despite these patients having multiple of these, we still, at least here at Lurie, we often will present these cases in our multidisciplinary epilepsy conference, because they will further work them up to see if there's one particular tuber or cortical dysplasia that could potentially be the largest source of their seizures, because if it is, they can potentially go in and resect that tuber to try to help decrease their seizure burden. So still super important to scrutinize these and correlate with their EEG. And then the other findings that we classically see with tuberous sclerosis are going to be these subependymal nodules. Dr. Susan Palacios, who is at CHOA, she and I and one of our former Emory fellows did a project where we evaluated whether or not you needed contrast in these tuberous sclerosis patients to see these nodules and to follow them. And what we found was you do not need contrast. All you need is to do, a 3D T1 sequence, get high resolution T2. Of course, sometimes these will have calcification within them, so a susceptibility weighted image is helpful, but they don't always calcify. And as long as you have those high resolution images, you should be able to follow these without contrast, which of course today is very important to try to decrease the use of gadolinium in our patients, especially our pediatric patients who are going to get multiple repeat imaging for surveillance. So just something important to keep in mind. So, if you're doing contrast for these, try to see if you can get away from doing that. And also to add on to what I was talking about for the angiomyolipomas, those can also be followed with an MR of the abdomen without contrast. So that helped when we were trying to get away from using contrast. So as you can see here, some of these subependymal nodules may enhance, some may not. Doesn't make a difference. But what's most important and why we continue to have surveillance of these patients is we will monitor the size of these lesions, especially if they're at this location at the level of the foramen of Monroe, because if they enlarge, they can result in hydrocephalus given their location, and that can also suggest that it has changed to a subependymal giant cell astrocytoma or a SEGA. In years past, they would have to do surgery to take those out, but now they will give them mTOR inhibitors, like I think it's everolimus, to decrease the size of those SEGAs to try to prevent having to do invasive surgery on these patients. So again, important to look at those subependymal nodules. Of course, look at the size of the ventricles to make sure that those are not slowly increasing over time, and make sure that they're not developing hydrocephalus. And then also we have Sturge-Weber Syndrome. So I know this is a mouthful, but I like to tell our trainees that it's more important to know what actually is Sturge-Weber Syndrome, since, not everyone loves eponyms and it's hard to remember, but it's actually encephalotrigeminal angiomatosis. I feel like if you know that, then you understand what's happening. So this is almost an entirely sporadic disorder. And again, based on the name, they end up getting angiomatosis of the face. So you'll think about that port wine stain that's usually in the V1 distribution. They also get angiomas of the choroid of the eye and of the leptomeninges. Of course, they will often present with seizures, hemiparesis, hemianopsia, and developmental delay. And what actually happens pathophysiologically is that they have this peel angioma, and then that angioma results in impaired venous drainage. And then the impaired venous drainage results in hypoperfusion of the underlying brain. And then that brain becomes atrophic and calcifies. And that's what we see on imaging. So here's an example of a case initially presented with a non-contrast head CT. We can see this faint, mainly looks like cortical-based high attenuation in this right cerebral hemisphere. So recommended an MRI for further evaluation. Hard to tell if that could, maybe it could be hemorrhage. It doesn't look that bright, but can't exclude it. And then on the MRI, we can see corresponding T2 flare hyperintensity, mainly within the leptomeninges and in that subarachnoid space, and maybe potentially also involving a little bit of the cortex because of the hypoperfusion and the gliosis. And then on the SWI, I think this was a MIP image just to make it stand out more, but we can see corresponding cortical calcification, which helps us know that that's the area of the brain that's being impaired by the Peel angioma. So in summary, I think I hopefully show that focal cortical dysplasia can be very subtle. So that's why it's very important to make sure that you're doing a dedicated epilepsy protocol. If you have questions about what should be included in the epilepsy protocol, happy to answer those. Of course, every institution is going to be different and every scanner is going to be a little bit different. And also important to take your time when scrutinizing these epilepsy cases, because as you've seen, again, the findings can be very subtle. It's important I try to tell all my trainees to make sure to go back and look in the electronic medical record to see if there is an EEG report, because if that EEG localizes to a particular area of the brain, you need to spend extra time scrutinizing and evaluating that area to make sure that there's not something subtle that could be causing the seizures. And then, of course, always looking for those cortical tumors in the setting of epilepsy. Some of the, imaging appearances of those can be variable, and it doesn't matter too much if they may or may not enhance, but still important to give contrast, because that can help you differentiate, as you saw in the one case, whether or not it's actually a tumor or just a cyst. So hopefully this was helpful. I'm happy to answer any questions. You can find me on Twitter or X at Judy Gadde, and feel free to email me. And then lastly, want to give a shout out to Usha. I don't want to butcher her last name. Maybe Adam can say it. She will be speaking on September 14th on phacomatoses. So hopefully she'll touch on a little bit of what I did and then expand upon that. Thank you.
Thank you so much, Judy. That was great. Yeah, a lot of stuff to look at, a lot of different entities that we're always dealing with, and yeah, some of these lesions can be very, very subtle. And it's a little, definitely always nervous going into reading these cases that I'm gonna miss something. Yeah.
Yes.
I was wondering if you wanted to talk about your epilepsy protocol, what kind of things you guys do, and then I guess any other advanced imaging or anything that you're adding, or if you want to talk about that.
Yeah, good questions.
Feel free to put them in the chat.
Thank you. So our epilepsy protocol is a little different from our standard brain in a few ways. So the things that make it stand out are that we do those the thin oblique coronal T2s that are angled through the hippocampi, which I think a lot of people do. And we also do a 3D T2 flare, because that can help find some of those areas of subtle signal abnormality. And that's it for our just like standard seizure protocol. That's the things that are different. But then we have a separate epilepsy surgery protocol where they either know that there's something or they're super suspicious, like pre-surgery. And for that, what we do is the DTI, because we don't do that on every case like CHOP does. And we also do what we call an axial T2 space, so a very thin high resolution T2, because that also can find some of those subtle signal abnormalities like in the white matter. And we do like an axial T1 space, like images they can use in the OR. And sometimes we'll do ASL. And then like regular workup for epilepsy, we'll do PET, brain, and we're getting a SPECT scanner. So it'll be interesting to see like how often we use that. And unfortunately, we don't have an MEG here, a MEG, but ideally we would have one. I think the closest one is in Milwaukee, but that can be helpful sometimes if they're not able to find a cause. And of course, fMRI, if we're, planning on surgery.
Yeah, we don't have an MEG here either, which is it'd be nice, but I don't think it's very profitable for the hospitals.
Yeah. And you need like PhDs and scientists to help you interpret them.
Yeah. Any questions or comments from the group?
Hopefully this was helpful. I know there was a lot to cover. Oh, question was from Kartik Reddy. Do you use MP2 Rage? So I learned about that maybe a year or two ago, and we have, I think it's an option. We really use something called FGator, which I think is along that same level, but the neurosurgeons tend to request that if they're planning surgery to like put in like deep electrodes more than for epilepsy. But yeah, I think something that we're still playing around with and learning more about. I don't know if you all use that commonly.
Yeah, so we just added it, and Kartik was kind of because this was spearheading that the epilepsy surgery protocol, MP2 Rage, and then doing that 3D Edge sequence that Eric Middlebrooks is kind of, have you seen some of his publications, makes a nice dark line along the gray white junction. I think we're still seeing whether how useful it is. We'll see. I think it's evaluating it, but it's adds some cool stuff. And yeah.
The other question he asked was how many directions. We do 64 for DTI. Thanks, Kartik.
Any other questions? Multi-shell diffusion?
I think, Kartik, you're going to have to educate me on that. Or Adam.
Yes, you can do like, for naughty, or so for neurite, or it's a little more complex. So you can do multi, for the neurite density and intra-axonal, extra-axonal spaces and stuff like that. But and did you guys have a PET MR?
We have a PET, but not a PET MR.
Yeah, we don't either. So it's another.
And I know CHOP, at least when I was there for fellowship, they had variable results, I think, using the PET MR. They tend to use it more for the MR than the PET, and even then it wasn't as good as like a standard.
Yeah. I think, I don't know if it's one of like the early generations. I feel like it's whenever you kind of jump on the newest technology. Sometimes it's not up to snuff all the time.
Yeah. Yeah, we end up just fusing the PET images to the MR, which I think has worked out fine.
Yeah, agreed. Any other questions from the group? How's your chance?
You can always message me later.
Yeah. Oh, you can always, yeah. So what do you call it? Xing? What do we call it? Or tweeting? What do we call it now?
I don't know. I'm just hoping everyone moves to Blue Sky, but I don't know.
Blue Sky.
Blue Sky is the new social media platform that Jack Dorsey, who created Twitter, is working on. So it's right now like invite only because it's not fully functional. I mean, it pretty much looks like Twitter or X.
Mhm.
You cannot do DMs though. I think that's like the major difference, and I'm not sure you can search hashtags yet, but
Okay.
yeah,
We're not using threads.
no.
Okay. Well, if no other questions. Let's see.
Susan, I have an invite. I have one invite. Some random person on Twitter tried to get it from me, but I will send it to you.
Sounds so nice, blue sky. Yeah.
Yeah.
Yeah. Okay, well, thank you so much, Judy, for this wonderful talk, and hope to see you guys next month. And for anybody who missed it, it'll be uploaded on YouTube shortly. Great. Thank you so much, Judy.
Sounds good. Thank you. Nice to see you.
You too.
Thank you, everyone.